Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland Oncology Hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.
Good evening and welcome to another episode of Oncology Radio. Oncology Radio broadcasts live from one of Maryland Oncology Hematology's 12 locations across Maryland. My name is Vivek Patil and I'm your host tonight. I am a colorectal surgeon and I am based out of the Rockville practice of Maryland Oncology and Hematology. Today's guest is Laurie Herscher. She is an integrative radiation oncology doctor in the Adventist Shady Grove Medical Center practice. Welcome, Dr. Herscher.
Thank you very much. Pleasure to be here.
So could you tell us a little bit about yourself, your background, and how you came to integrative medicine?
Sure. I'm a radiation oncologist, as you mentioned. I trained at the National Cancer Institute. And so in the many years of practicing radiation oncology, a lot of my patients would ask me questions about what else they could do to help, keep their cancer from coming back, or, what caused this cancer. And those were questions that I didn't really get any specific guidance or training on in my radiation oncology training. But those questions always, I always wanted to help, and they were interesting to me. And so my mind or my eyes would always, catch things that came across about, the impact of diet or exercise on cancer. But really what shifted was when I went to a meeting for the Society for Integrative Oncology, which was about 2011, which was amazing to me because I didn't really know that there was such an academic foundation for so many integrative modalities. And that inspired me to enroll in the Integrative Medicine Fellowship at the University of Arizona Andrew Wiles program. So I completed a fellowship in integrative medicine, and I'm currently board certified in integrative medicine and radiation oncology. And then since then, have been really focusing a lot more on integrative oncology, and was doing integrative oncology in addition to radiation oncology at the Aquilino Cancer Center.
Great, that's very interesting. And how do you, how do you define integrative medicine?
There's a lot of definitions. Andrew Wiles' definition is a way of providing care that uses all of the most effective modalities, whether they're Western conventional or non-Western conventional. So my way of thinking about it is trying to focus on what the cause of the problem is. So if somebody comes in with a some sort of cancer or autoimmune disease or GI dysfunction, rather than saying, okay, here, take non-steroidal anti-inflammatory for this condition if it's pain. What's causing the pain or what's causing autoimmunity? There's tons of drugs for autoimmunity now, really, high-powered anti-inflammatory type things. But there's a lot of evidence that autoimmune disease, for example, has a lot to do with the gut microbiome, for example. toxin exposure, things like that. So my way of thinking about integrative medicine has to do with kind of root cause analysis and trying to address those root causes to really promote wellness rather than treating symptoms.
That's great. And, this obviously being a colorectal surgeon, what's very interesting to me is of course gut health, which is a new sort of, I use new in quotation marks because obviously Eastern medicine or non-Western medicine has been thinking about gut health for thousands of years. But here in Western medicine, we've started to sort of stumble upon the idea of gut health being important to the person. Why do you think gut health is important?
That's a great question. Because if you think about the gut, I mean, there's a number of ways to look at this. If you think, first of all, the gut is basically a tube from, your mouth to your anus, that in the tube is still the outside world. Hasn't really been, the contents of your gut hasn't been taken into your body yet. So it's this huge interface between the outside world and the inside world. And the surface of the gut is huge. If you spread it out, because there's so many little villi and microvilli, it's about the size of a tennis court. So it's huge surface area where the outside world and the inside world are interfacing. Huge amount of the immune system lies just underneath the single cell thick layer of the gut. So the immune system is the status of the gut has a huge impact on the immune system, which has a huge impact on the rest of our body. So just for that one reason only, because the gut is such a important piece of immune function, that is a really critical node in how the whole system, if you think of we are an ecosystem, we are our own little ecosystem. All of our organs are, working together as a system. And I would say the, GI system is probably the most critical of that node, because we know that GI function affects all of the other systems. But if you think about it from a just purely, physiologically, what does the gut do? It's involved in digestion and absorption. If you're not digesting or absorbing well, you could be eating, great food, but you're not taking in, you're not able to assimilate all those critical vitamins, minerals, nutrients. If your gut permeability, the space between those single cell thick layer of the gut lining is not functioning well, you could be absorbing things that you shouldn't be absorbing, toxins, bacterial metabolites, things like that. And then that can, turn the immune system on, activate the immune system, and be the source of systemic inflammation, which a lot of people now are hearing a lot about systemic inflammation. The gut is thought to be one of the primary sources, for any number of reasons, of systemic inflammation. I kind of think of it like the lining of the gut is like the TSA at the airport, and it's trying to keep in or keep out what, shouldn't be able to go into the airport, and let the passengers who are, properly supposed to go into the airport, let them through. So the gut is so much more than just digesting food. It's really the gateway between, letting things in and keeping things out. And it has to let all of the good things in, and it's trying to keep all the bad things out. So it's huge, huge impact, and amazing that it's so, functional that it can do that. And the microbiome, which resides in the gut, which is basically this, can almost be thought of as a new organ or another organ. It said to weigh about 3 to 4 pounds. and it's said to have the metabolic activity that rivals that of the liver. And so,
wow.
yeah, it's really, I mean, this is all new information that's coming out. The number of hits on PubMed that have microbiome in them have, shot up in the last 10 years or so. But the microbiome plays a huge role in how the rest of our body functions. I think of it as kind of like a chemical factory. It's like our own little pharmaceutical factory or chemical factory in our guts, because bacteria eat fibers. They eat other things too, but mostly fiber. And then they make their metabolic processes make metabolites. And then our body uses the metabolites, and in a good, nice, balanced system, we're providing the bacteria with a nice, warm, moist home, and they're providing us with useful metabolites. Bacteria can make vitamins, and then it can go awry, and that's where you get into a lot of problems.
Yeah, I read somewhere that we're more bacteria than we are human.
Yeah, supposedly the numbers are something like 10 to 1 bacteria cells to human cells.
Wow.
But I've heard it's either somewhere 1 to 1 or 10 to 1. But there's no doubt that our genome is about 23,000 genes, but the genome of our gut microbiome is something like 100,000 genes. So the genome is so it's very it's resilient. It's more bacteria can respond much quicker to changes in environment than our genome can. So I think that's one of the reasons, if you could come up with a reason why we have so many bacteria. But bacteria has a generation time of 20 minutes, and of course our generation is much longer than that. So bacteria can respond to changes in the environment really quickly. So if they had to, they do change really quickly based on food that you eat. So if they need to respond to something, they can do it very quickly. They can proliferate very quickly and respond very quickly. So their genome is much more kind of responsive in short time.
And there's a gut-brain connection too, correct?
Yeah, that's another really interesting thing that we're kind of hearing more and more about, because we know that the vagus nerve, which is one of the cranial nerves that innervates the viscera, the GI tract, most of the fibers in the vagus nerve are actually taking information back to the brain. Something like 80%, somewhere in the 60 to 80% of the fibers are taking information back to the brain, and the rest of the fibers are sending information to the gut. And so what that means is that the brain is really, really, really carefully monitoring the conditions in the gut, which are giving us a very good sense on what's happening with the immune system. But the other point about that is that all of these bacterial metabolites can be taken up through the vagus nerve. And there's a lot of information about how inflammation, for example, can promote depression. There's certain metabolites that are associated with anxiety. There's even some data about certain metabolites associated with autism. This is a really fascinating area. It's, every day brings more and more information about this connection. But yet another reason to be very careful and want to take good care of your gut microbiome.
So along those lines, what recommendations do you usually give people to sort of care for their gut health?
Another really good question. The food, what you eat, is clearly the predominant modulator of the gut microbiome, because bacteria, and the microbiome actually includes bacteria, fungi, viruses, and other microbes called archaea. So it's not just bacteria, but these microbes feed on what we eat. And for the most part, it's fiber. And basically what fiber is certain kind of carbohydrate that we can't digest. So because of our enzymes, we don't have enzymes that digest certain kinds of carbohydrate bonds, but bacteria do. And fiber is the main food source of bacteria. And then because the microbiome is such an ecosystem, certain bacteria, eat fiber, and then they make metabolites that other bacteria eat, and it's a beautiful kind of symphony. But so you want to make sure that you're eating real food. That's the first thing I tell people, is eat real food, because processed food doesn't have the components that gut bacteria like to eat. And we know that. I mean, you know that because if you leave processed food on the counter, it won't get moldy, or it'll sit there, forever. And because bacteria, microbes, are not wanting to eat it. But if you cut an apple or a strawberry and leave it on the counter, within a day or so, it'll start getting moldy. You actually want to eat food that will that doesn't last very long on the kitchen counter, because if it lasts a long time on the kitchen counter, it's not feeding your gut bacteria very well. So eating real food is my number one recommendation. And real food is basically food that's most close to its natural condition. And so, cooking. Actually, probably the single best thing is for people to cook for themselves, because if you don't like cooking, it's not a good thing for your gut bacteria. So eating real food. And we have a problem. Yeah, go ahead.
Supplements, things like that. You don't generally, not that you don't recommend them, but you're not, you're sort of more along the lines of whole foods as opposed to a supplementation of, let's say, vitamins or probiotics or prebiotics.
Yeah, and I think in certain situations, prebiotics are basically fiber. Meaning it's, before it gets to the bacteria. Prebiotics are fiber. Sometimes it's helpful to supplement with fiber or certain kinds of fiber. Sometimes that can be helpful. Sometimes if people are having problems with, constipation or certain GI issues, supplementing with certain kinds of fiber. Or if you want to promote the growth of certain types of bacteria, it's known that certain types of fiber feed certain bacteria. I mean, that's an interesting, there's some new data, or relatively new in the last couple of years, that certain immunotherapy drugs don't work very well in people who are deficient in a certain type of commensal bacteria, friendly bacteria in the gut, called Bifidobacter. And there are specific types of fiber that feed Bifidobacter. And so Bifidobacter is also a probiotic. It's available as a probiotic. Not all of the bacteria that are known to, be friendly commensal bacteria in the gut are available, but that is one. So for certain situations, if somebody is known to be deficient in bifidobacter, and you can test stool to see how, what the relative amounts of certain bacteria are. But we're starting to get data about like how specific bacteria impact the efficacy of certain cancer treatments, and that happens to be one of them. So, for example, I have a protocol for patients who are doing immunotherapy with checkpoint inhibitors that includes certain types of fiber and supplementing with bifidobacter. But in general, you want real food and lots of different colored fruits and vegetables, because those actual colored pigments are food for bacteria, and the least amount of processed food as possible. Not only does processed food not have fiber, but processed food has a lot of contents or components to it that are actually antimicrobial. So processed food is bad on many, many levels.
So that's very interesting. And obviously those general recommendations you would give to, patients who have cancer undergoing treatment. Any specific recommendations for colorectal cancer as far as potentially prevention of it? Not that you could necessarily completely prevent it with just diet, but what things people might sort of do to try to prevent or decrease their risk of it. And then for those patients who unfortunately do have colon cancer, what specific recommendations you might have aside from the general ones we just spoke about?
Yeah, another really good question. So colorectal cancer is really interesting. I'm sure you know this, that it's one of the cancers that's really becoming much more common in young people than it ever was.
Yeah, unfortunately.
Which means in my mind, that means it's environmental, because genes don't change in, one generation. So, the question is like, what in the environment is promoting this really quite noticeable increase in young people getting colorectal cancer? And the microbiome is a huge, suspect in this. There's a lot of changes in the way people eat, and the use of certain pesticides. Glyphosate is one of them. That glyphosate is Roundup, and the way conventionally raised food has been treated over the last couple of decades. And some of the suspects are things like Roundup. Sugar. I mean, there is data about the increasing amount of sugar in the diet and that associated with colorectal cancer. And the biggest source of sugar in the Western diet is sodas. So sugar has so many negative effects on our system, but it also has a negative effect on the microbiome. So none of these effects are to only one piece of the system. So sugar is really bad for our own metabolism, but it's really bad for our gut microbiome. It increases some of the more pathogenic bacteria and decreases our more friendly bacteria. So my sense is that the increase in colorectal cancer rates in young people have to do with diet, but there's also data about increased risk with increased sedentary behaviors. There's circadian disruption, or light at night, or which I'm sure has something to do with the proliferation of devices at night and how people are on screens at night. So the general 5 categories of lifestyle interventions that make a big impact on cancer risk is, nutrition, diet, what you eat, exercise, sleep, stress management, and toxin avoidance. And all of those are players with colorectal cancer. Diet is probably, huge in ways that we've identified and ways that we haven't yet identified, because obviously the colonocytes are sitting there right next to the food that we take in and the microbiome. But all of those other lifestyle arenas impact, and they all impact on the gut microbiome. So there's just two-way streets all the way through the system. But I would say those are the 5 mainstay lifestyle arenas to pay attention to, with eating real food being number 1.
That's extremely interesting. And obviously those are all intertwined, as you said.
Mm-hmm.
You work out more, you get hungrier, you eat better food, you sleep better. These are all things that sort of go hand in hand. And these recommendations, I guess, being a surgeon, that's what is of interest to me. But you would recommend these, obviously, to pre-surgical patients as well.
Absolutely. And, there's some specific things that people can do, right before surgery to kind of shore up their intestinal integrity, because surgery is a big trauma. It's a nice, well-controlled trauma, but it is a trauma to a person.
Definitely.
And there's a whole, stress response to trauma. And one of the stress responses has to do with gut integrity, and glutamine, which is an amino acid. It's one of the most abundant amino acids in our bloodstream. But glutamine drops when we undergo big stress, like surgery or some other kind of trauma. And glutamine is one of the main sources of fuel for colonocytes, the cells lining the colon, which keep those tight junctions together. And so there's some data about using glutamine as a supplement prior to surgery, which keeps your colonocytes, intact, keeps that gut integrity intact, which is really important, because one component of bacteria called lipopolysaccharide, sometimes it's called endotoxin. So it's a toxin that's endogenous to our gut. Endotoxin, when those tight junctions loosen up, endotoxin is translocated or absorbed. And that's a huge impact on our immune system. It's like kryptonite for our immune system. And so that's thought to be actually what sepsis really is like a disintegration of your gut. The colonocyte integrity absorbing endotoxin, and then bad stuff happens. But we can be absorbing endotoxin on like a low level chronic basis. But glutamine seems to keep those tight junctions intact. So if we're recommending anything to do before surgery, it would be to supplement with glutamine. And sometimes pre-surgery protocols will have people taking whey protein, and glutamine happens to be highly one of the amino acids that's well represented in whey protein. So that's probably why it works.
I see. So as far as whole foods go, then I know a lot of physicians are starting to recommend a plant-based diet, and a lot of the data seems to be aligned with that. Do you think would you recommend that a plant-based diet as a standard diet for people? Would you recommend, cutting out meat altogether? What's your stance on that?
Yeah, another really good question. I'm never sure exactly what people mean by a plant-based diet, whether that means vegan or just means eat a lot of plants. I am actually not a fan of a vegan diet per se, because I think a vegan diet is nutritionally lacking. Like, you can't be like, I don't think you can be on a vegan diet without supplementing at least a few things that are just simply not available in plant material, which is like vitamin B12 and omega-3 fatty acids. I mean, you could be a healthy vegan if you are very careful about supplementing, but I don't think you could be a healthy vegan without supplementing those critical things. And there's other things that are found in animal food, but so I'm not a fan of the vegan diet. I am a fan of eating a lot of plant material. Greens, vegetables. The majority of what we eat could easily, and probably very healthy to eat the majority of our food as vegetables. Green leafy vegetables and other colored vegetables, because like I mentioned, these polyphenols, the pigments in vegetables, have so many beneficial effects, and vegetable material is fiber, and there's a lot of antioxidants, and so a lot of vegetable material. And then there's certain sources of protein that are just highly effective, or high value protein is mostly from animal-based foods, whether it's eggs. It doesn't have to be red meat, but I'm not against animal food, but I think in like eating just enough protein, not too much, healthy fats, and healthy fats mean naturally occurring fats, so not fats that are made in chemical factories like canola oil, but soybean oil, cottonseed oil, all those kinds of industrial oils are really bad. And then enough animal protein to satisfy your protein needs. I'm not against plant-based protein, because you can get protein in beans and lentils and things like that. I think probably most plant-based with using meat or animal protein as condiments is probably ideal.
That makes sense. Well, thank you for that detailed analysis. I think it was super helpful, certainly to me, and I imagine to our listeners. So as far as the sort of reason for this particular podcast is, I wanted to talk to you extensively about, where you stand and what your recommendations are. And I was going to talk a little bit about my experience with what I like to call integrative surgery, which is not really a real thing, but something I would like to make a real thing.
It should be a real thing.
And it obviously overlaps a lot with what you're doing and what you're talking about. So I think you had some questions for me regarding that as well.
Yeah, I think it's fabulous that you're interested in integrative surgery, because I think one of the things that we in the medical profession need to do is think about how to, like, we do great things, but like decreasing the side effect profile of a lot of our interventions. So I was interested to know how you became interested in, integrative surgery or the ERAS protocol, that I'm familiar with the term.
Sure. So the ERAS protocol is, ERAS stands for Enhanced Recovery After Surgery. It was something I was initially introduced to at our National Colorectal Surgery conference. It's an idea that originated in Europe, and a lot of the research was coming from there. I heard one of the main physicians who started over there, main surgeons, and he was just a fascinating speaker. And it sounded so radical at first. They were actually doing all the opposite of what we had been taught in surgical training. Now, a lot of that has changed recently, but certainly when I was in training, and I was still sort of using the same approaches that had been established, in the 40s and 50s by some of the sort of giants of surgery. So the way we used to approach gastrointestinal surgery patients was to keep them NPO, which is without food or water, for 24 hours prior to surgery. We'd operate on them, keep them again without food and water, supplement them with a large volume of IV fluids, give them a lot of IV pain medicine, keep them on bed rest, and then somehow, despite all that, they miraculously developed some bowel function, and then we would slowly feed them and then get them out. And that, they were in the hospital, 10 days, 2 weeks, sometimes with these kinds of surgeries. And through all that, of course, they're not sleeping well. Their mental status is changing in terms of the way they're feeling. And so none of these things were thought to be important. And what they were doing in Europe was basically the opposite. They were feeding people to ensure good preoperative nutrition, allowing them to drink fluids until a few hours before surgery, really giving them minimal IV fluids so as not to cause a lot of extra fluid within the gut, which can slow it down. They were encouraging, patients to get out of bed, as early as immediately after surgery, feeding them right after surgery. And so, I was blown away that anybody would even try this. And as I started to think about it afterwards, what seemed so radical was, appeared to be common sense. Is, why
Right.
are we asking, we're basically taking all someone's natural healing mechanisms and then opposing those natural healing mechanisms. As you said, a major on them, and then asking their bodies to basically heal without incident.
Mhm.
And so then I began to do, some more research into these protocols, and I felt like it was absolutely a necessity, for them for me to initiate that during this kind of during my surgeries. So a good thing is around that same time is not a lot, but some of the bigger institutions were kind of starting to move in that direction, and they began establishing protocols. So I felt that there was a validity there. And then, of course, now a tremendous amount of research has been done in the United States regarding these protocols, and they're very well validated and very well accepted, which is something I'm pleased with. So what I ended up doing is I teamed up with the head of anesthesiology at Adventist Shady Grove Medical Center and designed this inpatient protocol utilizing these elements that I had learned through the research. And as time has gone on, I've expanded the program to involve outpatient services, really so people can begin to be cared for as soon as they see me in the office.
That's fantastic. And I think what you said about enhancing the body's natural ability to heal is so important, because I tell patients that all the time, that the body does have a natural tendency to heal. And sometimes all we have to do is kind of get out of the way or create the optimized conditions for the body to do what it wants to do.
Yes, agreed. And I'm of the philosophy that, as surgeons, what your job is really to get out of the way, to have a light touch and get out of the way, not that your extreme interventions are somehow overcoming the body's natural healing mechanisms, and you're somehow forcing the body to do your bidding. I feel like the less you do, the better, and the more you can enhance the sort of natural course of things, the better off everyone's going to be.
Yeah, that's a very integrative medicine approach. Can you tell me, and what's the difference? Like, what are some specific differences in, I know you mentioned like about getting people eating and sooner and up and walking. Are there any other differences in the ERAS protocol versus standard?
Yeah, I mean, I think the main difference is really, what I alluded to is one of philosophy. It's the idea that, preparing your body and mind is an important part of the surgery process. And in fact, something that you cannot avoid, except at your own peril. Which is something we never considered as a field before. The old way was to basically discuss surgery extensively with the patient, and then the next time they would see you would be on the day of the procedure. One thing I love about ERAS is not only are you sort of optimizing the patient before surgery, but the surgical team is sort of walking with them through their whole journey. It's sort of a person-centered holistic surgery. And that, I think, is the big difference. As far as, specifics, I think, some of the very standard elements to this protocol, which, if you were going to establish one, you need to have. One is really in-depth, nutritional counseling before surgery. So, really kind of going through what a patient is doing, as you said before. Ideally, are you getting the patient towards a more whole food diet? Are you telling them about, recommendations of things that they can do to prepare their gut before surgery? You also are evaluating a person's activity level and their basically, how fit they are, their sort of fitness level, and then you're intervening on that. Obviously, some people don't need as much intervention as others, but that's the beauty of the protocol, is you can sort of give as little or as much as needed per patient. And then, you also want to focus on things like stress management and, any social issues that may be complicating or may cause complications throughout the surgical process. Within the inpatient protocol, once the patient, that's all outpatient stuff. Once they get to surgery, in the operating room, what you're doing is you're limiting their IV fluids so as not to sort of flood the gut with fluid, which, can slow down motility. You want to really give as much non-narcotic pain medicine as possible, either, medication, or sometimes we do local blocks with local anesthetic under ultrasound guidance. And the idea is to, again, take some of that opiate burden off the patient while still providing adequate pain relief. Once they get to the surgical recovery floor after surgery, we're starting the oral intake process right away. We're giving people liquids right off the bat. We're encouraging them to get out of bed even on the evening of surgery, after surgery. And we're really, we're encouraging them move around, get out of bed. I tell people, things like, if you want to bring your own clothes so you can wear them, you'll feel less like a patient. All of these little things, just help with the recovery. And so those are some of the specifics, and they've been very helpful in my patient population.
That's fantastic. I mean, that is such an integrative approach. It reminds me of like back, when I was in training, we had much more of a tendency to tell patients who were undergoing treatment with radiation to rest. like rest,
Yeah.
just rest. Now, no.
Yeah.
Like stay active, like, because activity breeds energy, and so it's kind of similar to what you're describing.
Yeah,
Getting
exactly.
people up. Like sitting around in a bed and not doing anything is terrible.
Exactly.
How have you been? Like looking at specific metrics on how people are doing with the ERAS in terms of like how long they stay in the hospital or how much narcotics they are using?
Yes, basically, it's important to, with these protocols, to make sure that you're analyzing it along the way to make sure you're actually having an impact. You want to ensure compliance, that patients are doing the right things, that things that may not be very helpful for your patient population, you can eliminate. You might need to add things, and then of course, what are your outcomes? And for me, I collected about 3 years worth of data and did an analysis on it. And one things that I was interested in is if we are optimizing people's health and well-being before surgery so that the recovery process goes smoother, does that mean they can leave the hospital sooner? Does that mean they might use less pain medicine? Might they have fewer surgical complications? So in doing that process, I have, my data shows what is similar to actually a lot of the data that's out there now on these protocols, is that there is a definitive length of stay decrease, meaning patients are leaving the hospitals faster. Commensurate with that, the readmission rates have not changed. So it's not that you're getting patients out faster and they're coming back again.
Right.
They're going home and they're staying at home because they're just feeling better quicker. For me, it was about a 2-day decrease in length of stay. There was also a significant decrease in the amount of opioids we use, almost an 80% decrease in the amount of opioids we use. Yeah, so that's been very gratifying. As far as complications go, that hasn't changed much, and that's also similar to the data. There's these measures haven't been proven to sort of improve the surgery itself, but they certainly improve the patient's recovery process. And again, they're not coming back; they're not having worse complications. It's been a very much net positive for these protocols.
Yeah, I'll say. Were you surprised at the degree of impact on those measures, on those outcome measures from these types of integrative approaches?
That's a good question. I was surprised. I wasn't, and I was. I wasn't surprised because the research out there is basically been similar to what my anecdotal findings are, and this data analysis sort of proved it. There is always going to be if done appropriately, it's going to be a decreased length of stay, less opioids, and no change in readmissions. So it was sort of right on track. It was gratifying to see that. What fascinated me was this idea of all of this is decidedly low-tech stuff.
Yes.
I didn't have to buy any equipment.
Right.
We're not, spending millions of dollars to affect these monumental changes. It's this power of the small change. And that was what I found to be the best. It's almost a thumb in the nose to, the industrial medicine, to say, hey, we don't need the largest, sort of research studies with the fanciest drugs and equipment. We can do this with small changes. And we're partnering with our patients and we're all aligned and it's working.
I think that's such an important message, because I think in oncology, we see, obviously cancer treatment is hugely expensive, and there's data like walking 30 minutes 5 days a week, 150 minutes a week, decreases the overall mortality of breast cancer by 6%. 6% might not sound like a lot, but as a single intervention, I mean, some of the chemotherapy drugs don't provide 6% benefit.
Sure.
So it's completely low tech, like you said, and doesn't require any fancy equipment, and doesn't cost anything. And here you go. You see, it's working with the body. It's working with nature. And that's just one tiny intervention, and that's not even talking about everything about food and all the other pieces. You can make a big impact. You can make a big impact with these low
definitely
interventions. What's next for ERAS?
So, I now that I'm in it, I can't stop doing it, and I can't stop thinking of the next thing. And for me, what I want to try to see is really develop more robustly the outpatient aspect of it. What other assistances can we give to patients? Are there, things that might help them with compliance for this protocol? Are there, wearables that might be helpful? Are there, is there better screening for people so we can intervene earlier in things like social issues or, psychological issues that might be barriers to care? These are the kinds of, roads that I want to go down going forward.
Are there other surgical service lines at Adventist that are initiating ERAS?
Yeah, so I have been working with general surgery, and I'm also starting early, and we're in the early stages of working with breast surgery because I think this would be very helpful for this population of patients as well.
Well, I think what you're doing is absolutely fantastic. It's really, warms my integrative medicine heart.
I appreciate it.
Yeah. I mean,
it's great to have a partner like you.
There's so much we can do. There's so much we can do.
Yeah, absolutely. Well, thank you very much, Dr. Herscher. Would you like to share your website or contact information? And if, just so people who are interested may be able to reach you.
I would love to. I'm in the process of developing my website because I'm going to be starting a private practice doing integrative oncology probably within the next month. But
that's great.
I don't have that contact information quite yet. But I'll make it available to Maryland Oncology and Hematology so that if anybody would like to get in touch with me, they'll know how to send you my way.
Sounds great. Thanks once again. And thank you for listening to another episode of Oncology Radio. Have a good night.
Thanks for listening to our latest episode of Oncology Radio. You can find the broadcast on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. You can find more information about our physician hosts from Maryland Oncology Hematology at www.marylandoncology.com. Subscribe to our show on Spreaker at www.spreaker.com/user/oncology radio. And remember to follow the guidelines and get your cancer screenings for the best defense against cancer.